Good evening, everyone. Thank you so much for joining us tonight. Welcome to the third part of the Diabetes and Metabolism webinar series hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. My name is Rose Young, and I am the Medical Director of the Office of Lifelong Learning and Physician Learning Program, which is committed to providing reliable advice and resources for healthcare providers, scientists, and everyone committed to addressing the challenges related to diabetes and metabolic disease. So I would like to start with our land acknowledgement. So we acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. I also want to acknowledge that this Friday is the National Day for Truth and Reconciliation, and I hope that everyone will have a chance to reflect on the continuing impact of colonization and find ways to honor residential school survivors. I am very pleased that tonight Dr. Kate Potter will be presenting the top 10 pediatric hormone tests that are generally ordered. And Dr. Potter will explore the usefulness and nuances in ordering lab and X-ray tests to assess puberty and adrenarche in children, and we'll discuss tests to guide management in pediatric thyroid disease. Dr. Potter is a Calgary-based pediatric endocrinologist. She completed her MD PhD program at UBC, followed by pediatrics residency at the University of Calgary. And then we had the pleasure of having her in Edmonton for pediatric endocrinology subspecialty training. She is very busy clinically, having a pediatric diabetes practice spanning Red Deer Medicine Hat in Calgary. She is passionate about teaching and patient-focused advocacy and manages to continue doing research with Dr. Rabassa-Lorette in Montreal, and is heading the first cystic fibrosis-related diabetes guidelines in Canada. And congratulations, Kate, on that work. In her time off, you can find her at the dance studio, in the mountains, or on the coast. And with that, welcome, Dr. Potter, and thank you for enlightening us tonight.
Thank you so much. So I'm delighted to be here. If at any time you need me to slow down or speak up, just let me know. So tonight I am excited to take you on a road trip through the top 10 pediatric endocrinology tests. A lot of people tell me I seem like I have the best job in the world, and I really think so. So I'm delighted to share this with you. This is a summary of the tests I'm going to go through, and it's by no means comprehensive, but I had to pick 10, and there's probably a few more that I snuck in there anyways. So we're going to look at bone age x-rays, and then we'll move into actual lab tests and look at growth hormone and IGF-1, pituitary puberty hormones, testosterone and related tests, progesterone and 17-hydroxyprogesterone, prolactin, and then spend some time on thyroid tests. So bone age x-rays are sort of like an ECG for endocrinologists. We love it if you've done a bone age x-ray when you send a referral. And this is a paper that borrowed some images from a 1955 book by Grulich and Pyle, and we actually still use this book. I use it every day. What a bone age is it essentially looks at how much time is there left until complete maturity of the bones when there's no more room left to grow. So what I like to tell parents is we're looking at how much space is left in the bones. And when you look at really little people, like on the left, you can see that the small bones on the wrist will calcify over time. And there's a very clear pattern about that. And so and in the next slide, I'll give a little bit more detail. And later on, we're looking more at the little epiphyseal caps in all of the finger bones. So on the left, this is essentially a figure that shows in orange the changes in the bone that are associated with each age. And so what you see is in a newborn x-ray, you really don't see any of the wrist bones because they haven't calcified yet. And by about 24 months, you start to see little caps on all the epiphyses of the longer finger bones. But really up until about age 5, we're mainly looking at the wrist bones. And then as we start to get into the peripubertal and puberty years, we're mainly looking at the size of the little caps on all of the longer finger bones. And so bone ages give us a relative idea of if a child is growing on time, if their growth is delayed and they have extra room to grow. So I always use the term the late bloomer pattern, or if they're advanced, whether it's constitutional advancement or something else. And so very roughly, a bone age that is about 2 years behind. So if you're 4 years old and your bone age looks like you're 2, I would say that's a delayed bone age. And 2 years ahead, so if you're 4 and it looks like a 6-year-old, I would call that advanced. And that's my rough approximation, but it's usually pretty accurate. And a lot of people think that bone ages are very, very precise. And really, there's a range. It's a relative. Do we really think that there's an advancement or a delay or not? It's not quite as precise as we'd love it to be. What else to know about bone age x-rays? So when should you order it? If you suspect that there's either delayed or advanced puberty, it's a really good idea. If someone has really short stature, if someone has tall stature, especially if we think that they're going through puberty early and they're tall because of that, and we want to know, are they advancing their bone age too much because of early puberty? But if a mid to late teen is not growing, we get a lot of referrals for kids who've stopped growing. So typically girls stop growing about a year after their period. By the time you get your period, except in the few unusual cases, typically you've got around 10 centimeters left. And a boy will typically stop growing around 15. And when you order a bone age and you look on Netcare, you can actually click on the link and look at the bone age. And so if there are no more little caps on each of the little fingers, but the bones look mature, there's no more little spaces at the end of the bone where a growth plate would be, an endocrinologist can't actually offer any intervention. So especially if you have someone who's coming in and they're like, my daughter hasn't grown in 2 years, we're really worried about it. It's always really helpful to take a look at that x-ray just to say, do we think the bones are closed or not? And certainly send a referral along regardless. And but an endocrinologist might come back to you if they're done growing and just say there's literally no intervention we can do once the bone age is closed. The other big thing is if the results of a bone age x-ray don't make sense with the clinical picture, always consider asking an endocrinologist to read the bone age for you. And whether that's on call or sending a referral, I know we're always happy to speak to people in between clinic patients. And that's because there's a recent paper that came out showing that there's actually a lot of discrepancy in reading bone ages. And especially between pediatric endocrinologists and radiologists. So we're often refining and looking at bone ages ourselves. So it's an imprecise tool, but it does give us an idea about whether we really think someone is growing too fast or too slow. And in short stature, it's also really helpful for height predictions. So just for fun, this is a program out of the States. It's called Bone Expert-AHP, and AHP stands for Adult Height Prediction. And this is validated for adult height prediction if you're 7 years or older. And so you can see that you can put in whether you're male or female, you can choose ethnicity, and then you can play with it and put in what the bone age is, the actual age, the height, and mom and dad's heights. And you can get a sense of when you think the peak height velocity will be, the expected height based on the x-ray, the expected height based on parents alone, and then the actual height prediction based on all of this information is the AHP X plus P. So you can compare the AHP parental to the X plus P just to get a sense of, do we think that a child is growing to meet their genetic target? And their genetic target would be essentially estimated by the AHP parental. So it's just a kind of a fun tool if you ever wanted to play with it. Moving into the next test. And so nothing else is imaging, but we thought the bone age was actually quite important and we should go over it. So I'm going to shift gears and focus on a lot of what's really critical to endocrinology, the hypothalamus and pituitary and the many pathways that are associated with the complex hormone feedback that they drive. So we're going to start with growth hormone. And just to give you a really quick review, going back to medical school, the anterior pituitary makes about 8 important hormones, and we're going to focus on growth hormone. And it's controlled higher up by the hypothalamus. And so the hypothalamus makes growth hormone releasing hormone to stimulate the pituitary to release growth hormone. And then there's also an inhibitory factor that can come from the hypothalamus. Growth hormone can act on target organs, which are bone and connective tissue and muscle. But most importantly, it acts on the liver to have it make a protein called IGF-1, or insulin-like growth factor. And insulin-like growth factor does most of the heavy lifting for growth hormone. So it essentially is the main mediator of growth hormone, although growth hormone can also act on target organs. And I'm going to pause there and go into the lab test. So the first question we get is, can and should I order a random growth hormone test? And the overall answer is no. So growth hormone tests are really limited to about under a month of age and very specifically ordered by an endocrinologist under very specific circumstances with a really focused question. And so I wouldn't recommend doing a growth hormone test. What you can see in the figure on the right is some growth hormone levels over 24 hours from a bunch of random subjects. And what you'll notice is there's a lot of variability, and also no person is the same. And so we can't really measure a random growth hormone because it doesn't really mean anything. As I go to the next slide, what should I do? So really, IGF-1, or insulin-like growth factor, is really your serum screening test if you want to get a sense of, are we worried about growth hormone? And it's not the be-all and end-all, but I think it's a really important test that gives us a rough idea of, do we think there's a growth hormone problem? So when do we consider doing an IGF-1? So if you have a growing child with short stature, if you have a growing child with a declining growth velocity, and just to give you a rough estimate of what the growth velocity should be, if you look on UpToDate, there's a lot of ranges for under 2 years old because it changes according to how many months old you are. But in a preschool or a prepubertal school-age child, the normal growth rate is about 4 to 6 centimeters a year. And then as kids go into puberty, in early puberty, they kind of grow 7 to 10 centimeters a year. And then boys hit their peak height velocity in puberty about 2/3 of the way through puberty, and girls, it's about halfway through. Other considerations would be if you had a child falling across height percentiles. And one thing that's really important, if you're going to do an IGF-1, the screening question is really important because a lot of people mix up short stature or a declining velocity and height with failure to thrive. And so these are scenarios where we're not worried about a malnutrition problem or a weight problem. We're really specifically looking at short stature or a decrease in linear growth rather than a nutritional or intake or malnutrition problem. This is just a smaller part of that other figure I showed before, just to show IGF-1 up close. So IGF-1 is made by the liver in response to growth hormone, and then it acts on target organs on the IGF-1 receptor. And again, this is bone, connective tissue, muscle, and other cells. A few other important considerations about IGF-1. If you have a child with a constitutional delay, so say for example, their bone age is 2 years behind their chronological age, you need to interpret their IGF-1 level with an IGF-1 level that would be corresponding to their bone age. So you can't always directly compare the IGF-1 range that pops up on Netcare. So if you have a child who has a delayed bone age or an advanced bone age, you might want to consider going on to the Alberta Precision Lab site just to see what the growth hormone, or the IGF-1 range would be for the age that their bone age is showing that they are. The other thing is IGF-1 isn't a perfect test. So it's a good screening test, and it can suggest a problem with growth hormone. Some of the IGF-1 assays are more sensitive than others, and this is my biased experience, but I found that the one in Edmonton during my fellowship was maybe a little bit more sensitive. And bear in mind the assays change, so it may have changed since now. When an IGF-1 is normal, but you're worried about a clinical problem, whether it's short stature or declining growth velocity, still refer to pediatric endocrinology. Don't do an IGF-1 level and say, well, it can't be a growth hormone problem because the IGF-1 isn't low. It's a great screen. If it is low, it tells us a lot. But if it's not, it's just one piece of the puzzle that we're going to look at. And if we're worried about a growth hormone problem, even with a normal IGF-1 level, that's where an endocrinologist is going to go on and consider other tests, especially a stimulation test that would be done at a hospital to really look at a growth hormone response. So IGF-1's good, but it's not the only part of the puzzle we look at. The other thing is IGF-1 can be low for reasons other than if you have a growth hormone problem. So there are some genetic reasons that are very rare that you'll probably not encounter, but malnutrition, anorexia nervosa, chronic liver or kidney disease, and high dose estrogens can all also make the IGF-1 level low. I'm going to move on to two other important hormones, so also made by the anterior pituitary. So LH and FSH are the important pituitary mediators of puberty that come from the brain. So the hypothalamus talks to the pituitary and uses a hormone called GnRH, or gonadotropin releasing hormone. I'm just going to focus on a really quick point on this. When we are using medications to stop precocious puberty, we're actually using a synthetic form of GnRH called Lupron, if you've ever heard of that. So GnRH stimulates the anterior pituitary to make FSH, or follicle stimulating hormone, and luteinizing hormone, which stimulate the gonads, either the testis or the ovary. Follicle stimulating hormone is very important for stimulating the gonads, so to make spermatogenesis, and also plays an important role in ovulation. LH also plays an important role in ovulation, and then these hormones are quite important for the downstream mediation of making, for girls, estrogen and progesterone, and for boys, testosterone. This is a graph to show that FSH and LH secretion changes over the lifespan. One of my favorite fun facts about LH and FSH is that there's actually a mini puberty of infancy. So LH and FSH are active in a fetus, and then by the third trimester, maternal hormones will really turn them off. But after a baby's born and maternal hormones are washed out, you actually have a rise of FSH and LH. And so these hormones can actually be turned on up to about a year of age, or in little girls, even up to 3 years of age. And then by the toddler years, there's an FSH predominance, and FSH and LH they're made, but at very, very low levels. And then as you get into childhood, LH is suppressed. Sometimes FSH will be turned on, but LH is definitely suppressed until you get into the pubertal years. In the pubertal years, it shows an LH predominance. The other thing that this figure doesn't show is that in the very first stages of puberty, the gonadotropins or essentially LH and FSH only turn on at night. So in the really early stages of puberty, if you're doing a blood test to say, is this child in puberty, they definitely could be in puberty, but their hormone levels could look like they're not turned on a blood test. And that's just because we're not measuring blood tests in the middle of the night. And then as you progress through puberty, the amplitude of LH and FSH gets much bigger. And then as you get into the sort of senior years, there's more of an FSH predominance. And really importantly, if you also have premature gonadal failure, you'll also see an FSH predominance and a rise in LH and FSH. So really interesting pattern of FSH and LH over the lifespan. This is also just a really quick refresher on Tanner staging. I really like a site from Learn Pediatrics from the University of British Columbia. And we always want to make sure that you're interpreting your LH and FSH relative to a clinical exam. And again, this is also from the same website, and it just gives a good overview of the stages. The first one is breast development, and the second is of pubic hair development. Considerations about FSH and LH. So when should you consider ordering them? So if you have an infant or a toddler where you're worried about precocious puberty, um, then I would definitely order them. The one thing to know about is with that mini puberty of infancy, sometimes FSH and LH will be turned on even when it's not precocious puberty. And there is a condition where little girls have breast tissue up to a 10 or 3, and uh, we're always in a toddler who has breast tissue. We're always trying to figure out, is this just benign premature telarchy that will go away over time, or is this actual puberty? And so definitely whenever if you have FSH and LH turned on, and there are pubertal signs, it's always good to refer to a pediatric endocrinologist. The FSH and the LH, you can't completely rule out premature telarchy and some other related diagnoses when they're positive in a baby, but when they're positive and they do have an exam that seems quite abnormal, that certainly should be referred to an endocrinologist. In children, I would do an FSH and LH when you suspect precocious puberty. So we typically say before 8 in girls, although in some African American populations, puberty actually starts between 6 and 7. And precocious puberty in a boy would be under 9 years old. And really important, especially in a boy, when you think there's precocious puberty, there's a much higher chance of an underlying pathological cause. So really important to see if LH and FSH are turned on if you think that that is a concern. In adolescents, if there's either delayed puberty or incomplete puberty where you start it but you don't think that they finished it, if there's amenorrhea, or if you're doing pituitary screen in general for a number of reasons, that would be when I would consider doing an FSH and an LH. This will change between assays, but generally I was taught in fellowship that an LH over 0.3 means that you are in puberty. And I do find this to generally hold true for all of the assays across Alberta, having worked in both the north and the south parts. FSH and LH can be turned on in infants, and that's because of mini puberty of infancy. So if they are turned on and you're worried about precocious puberty, you actually can't rule it out just based on a blood test. And then I mentioned this a little bit earlier, but if you do an FSH and LH level because you're worried about precocious puberty, and you think a little girl has like 10 or 2 breasts or even 10 or 3 breasts, and the labs come back and you're like, okay, well, she doesn't have puberty based on her labs, that doesn't mean that she's not necessarily in puberty. So a clinical exam is really important to interpret along with FSH and LH. Just like for IGF-1, you can't just look at the results and have an answer. It's really a part of the puzzle in the whole clinical picture. Major points, I'm repeating some of these a little bit, but if you're worried about puberty in a baby, FSH and LH can be normally turned on. So the clinical exam is really important. And when you feel a little bit nervous, you're not sure what's going on, just have a low threshold to talk to your local friendly pediatric endocrinologist. If you're worried about delayed puberty, if FSH and LH aren't detectable, that doesn't mean that a child is not in early puberty. And so definitely also look at your clinical exam and consider Tanner staging. In hypothalamic amenorrhea, FSH and LH can be low, but in the vast majority of cases I've seen, they're usually turned on. And so you would detect them on a blood test. So clinical history is really important. And then an elevated FSH, especially FSH higher than an LH, can be really important to detect ovarian and testicular failure, especially when FSH starts to get over 15 to 20. To talk about some of the downstream hormones, testosterone. And in the next slide, I'll talk about the free androgen index. So when do I actually order a testosterone? So in males, if I'm worried about delayed puberty, and delayed puberty in a male would be after like no signs of puberty by 14 years old. Delayed puberty in a girl would be no signs of puberty by 13 years. So in a male, if there's delayed puberty or if there's advanced puberty or precocious puberty. And then in females, to assess PCOS or hirsutism or virilization. And I just put up a reference with the testosterone ranges in Alberta that you'll find in the Alberta Precision Lab site. And it's actually the same for both Edmonton and Calgary, and so the whole province. And what's really important is that the ranges changed about a year ago. So for example, a normal testosterone in Calgary about 2 years ago for a female would have been under 1.1, whereas now it's under 1.7. So if you're looking at more historical labs, just remember that the reference ranges have changed. I usually just do a testosterone. There's one case where I'll also do the free androgen index. So the free androgen index, I like to say, is essentially how do you say how much testosterone is floating around? So testosterone, the majority of it in the blood is actually bound up to a protein called sex hormone binding globulin, which tends to be low in PCOS or polycystic ovarian syndrome. When you order a free androgen index, the results you get are the top number will be the free androgen index. And if it's over a certain value, and I've shown the reference range for the free androgen index in Calgary and then Edmonton, and so you know these two assays are quite different, then it'll be highlighted. So if it's over 5 in a female, that's where I start to say, oh, I wonder if this is PCOS. It'll also show the sex hormone binding globulin, which typically is low in PCOS, and then it shows the total testosterone. And the reason I do it in some cases of mild or what I suspect is PCOS is really just to say if the testosterone's normal, but I really want to know, is there any lab evidence of hyperandrogenism? Is the sex hormone binding globulin low? And do I think there's more free-floating testosterone that could be explaining the clinical picture than I would see if I just did a total testosterone? The one thing I will say is definitely not all endocrinologists will do a free androgen index. In my training in Edmonton, we didn't really do it, and it was a little bit more common in Calgary when I moved back. The next one is a progesterone. So progesterone is a precursor to many steroid pathways, or many steroid hormone pathways, and it's commonly measured in adult female reproductive endocrinology. It theoretically does make sense to measure it, as you should be making it in the second half of the period cycle, but I never actually use it. So if I'm worried that a girl has had periods for over 2 years and that they're irregular, for a functional test, I might give a course of Provera, but I never actually order progesterone, and no one in my training or amongst my colleagues really does. We more rely on a functional test. So we really don't order a progesterone, and usually it's more ordered by the adult world. But we noticed that a lot of people who send referrals actually measure it. And the reason I actually brought it up is because we see it so often. And sometimes what we wonder is if you meant to order a 17 OHP or 17 hydroxyprogesterone level. And this is a very specific screening test for a very rare endocrine condition called congenital adrenal hyperplasia, of which 21 hydroxylase deficiency would be the common one. So this is a mouthful, and I'm throwing a lot at you. So in the next slide, or in the next 3 slides, I'm going to try to explain this. So 17 hydroxyprogesterone is a screening test for the most common form of congenital adrenal hyperplasia, which is 21 hydroxylase deficiency. So I have tried to simplify the very complex pathway of how adrenal steroids are made. So I always tell families that the adrenals are like the little Mexican hats that sit on top of the kidneys, and the inside part of the adrenal makes adrenaline. The outside has 3 different layers that make really important hormones. Everything starts with cholesterol. So cholesterol is actually very important for adrenal steroid hormones. And then there's a series of very important interlinked steps that I've represented with the arrows, but I didn't want to overwhelm people with the very, very complex biochemical cascade. So cholesterol is turned into pregnenolone, and then that can be made into aldosterone by 5 different steps. And aldosterone is a really important hormone to maintain blood pressure and for sodium-potassium balance. Pregnenolone can be converted into 17 hydroxypregnenolone, and in 3 steps, it's made into cortisol, which is critically important for life. It helps blood pressure, but as everyone knows, it's very important to fight infections. So if you don't have cortisol, you are very, very unwell. And then finally, 17 hydroxypregnenolone can also spill over into a final pathway with a very complex cascade that makes the sex steroids. And these are weaker testosterones or weaker androgens that are important for secondary sex characteristics like acne and pubic hair, body odor. So in the adrenal gland, cholesterol is turned into important hormones for blood pressure regulation, to fight infections, and for secondary sex characteristics. If one step in the complex pathway doesn't work, then it can have a major impact on hormone levels, like I'm going to show you in the next slide. And in the next slide, I'm going to talk about a severe form of when one enzyme isn't working the way it should, and that's the 21-hydroxylase deficiency. So I know this is complex, but it is for a reason. So when 21-hydroxylase is deficient, the amount of enzyme activity determines how severe the condition is. And so essentially what you see is where are the X's, that's showing this one step, this enzyme that's important in making both aldosterone and cortisol. So if there's a really severe block, then you actually don't end up making enough aldosterone and cortisol to support the body's functions. But you've got a lot of extra hormone hanging around. So it's kind of like a plugged sink. All of the extra pregnenolone and 17-hydroxypregnenolone that aren't turned into cortisol or aldosterone spill over, and you get a lot of extra sex steroids. So what do we see? This is actually on the metabolic screen the heel poke we do on all babies, just because infants can get so sick so quickly if this is missed. In the very severe form, it happens in infancy, and male infants will actually look very, very normal. Female infants who have this condition and are detected at birth can have ambiguous genitalia, usually a very large clitoris, but there can definitely be other changes, and that's from very high levels of weak testosterone. Infants can go into a salt wasting crisis and are also at risk of adrenal insufficiency, and certainly it can lead to death if it's missed. So it sounds terrifying, but it's on the metabolic screen, and if you have a patient who on their metabolic screen has a 17-hydroxyprogesterone that's high, endocrinology will automatically be consulted, and you'll definitely hear about them seeing the endocrinologist very, very quickly. The next slide shows why this screen's a little bit more relevant in community practice. So when 21-hydroxylase is deficient, but it's a very mild enzyme block, you definitely make enough cortisol and aldosterone, so you never have any problems. These are patients who never would have an adrenal insufficiency. Really what you notice is either they grow too fast, or there's evidence of having too many sex steroids around, just because there's still an overflow of the pregnenolone and 17-hydroxypregnenolone. And so in the mild form, it can look like severe premature adrenarche. So you can have kids who grow really, really quickly, have really bad early acne before the puberty years, an advanced bone age, or who have pubic and body hair under 8 in girls and 9 in boys. And or it can look like PCOS. So very commonly, when do we actually do this in community practice? The majority for when I would consider ordering in the community would be if you think a girl has PCOS, we very commonly will actually, because if it presents in the teen years, do a 17-OHP just to say, do we think that it's a rare form of congenital adrenal hyperplasia? And typically it's actually treated, if it's the late onset form that looks like PCOS, it's actually treated like PCOS, but it also gives important information in case a girl was ever going to go and have a pregnancy later and could have a fetus at risk. So I realize that's very complicated, but just because there's so much progesterone that's ordered, and very often it's ordered when there's a referral for PCOS, I just wanted to point out that just make sure everyone understood the difference between a progesterone and a 17-OHP level. I promise that's the most complex pathway I'm going to throw. So when should you consider ordering a 17-hydroxyprogesterone? So it's ordered on the newborn metabolic screen. A positive screen would notify the local pediatric endocrinology team to see the infant, and they'd also get in touch with the family physician. In an infant who has pubic hair or other features of being very hairy, having body odor, really bad acne, or ambiguous genitalia, and those would certainly go to pediatric endocrinology. If you have a child with premature adrenarche, often I like to do a 17-OHP level, and in adolescent girls with severe hirsutism or suspected PCOS. And then for interpretation of a 17-OHP, I would definitely send to endocrinology if you're worried about it. The next one is prolactin. And I'm not going to go into this in too much detail, but I think it's too important of a hormone to miss. And there's some very finer points that I've left out. So if we just look at the prolactin pathway, prolactin is made by the anterior pituitary, but usually it's suppressed. So in the hypothalamus, there are neurons that send dopamine down the pituitary stalk, which suppress release of prolactin. TRH is thyroid releasing hormone, which can stimulate the release of prolactin. And we don't want prolactin turned on except at very specific times. So typically for breastfeeding. And so there are many physiological causes that can turn on prolactin. For example, a baby sucking on the breast, or if someone stimulates the nipples, those actions can have feedback that can turn on prolactin and overcome some of the dopamine inhibition. And then there's also a number of medications and some pathological causes I'll get to in the next slide. So prolactin physiologically can be increased. And this is really important because when you're getting a positive prolactin level, but it's fairly low level, and I'd consider that like 30s, it often is really just related to some physiological hormone conditions. So I've had referrals where someone's worried that a prolactin of 20 could be a prolactinoma. And very typically, a low prolactin or a very weakly positive prolactin that's sort of above 15 but under 30 very often is due to stress. So stress of phlebotomy, pregnancy, breastfeeding, nipple stimulation, intercourse. So there's a lot of different physiological things that can stimulate it. The vast majority of kids that I see with a slightly elevated prolactin level, really it's because they were really stressed when they went to go get their blood drawn. Some medications, especially atypical antipsychotics, and so there's definitely important monitoring protocols for kids who are on atypical antipsychotics to monitor prolactin levels. Some antidepressants, though less commonly, metoclopramide, domperidone, and some calcium channel blockers. And there's an extensive list, but those are some of the most common. The ones we certainly worry about when most of us are ordering a prolactin would be a pituitary adenoma. If there's damage to the pituitary stalk so that you lose the effect of dopamine turning off prolactin, or if there's any disease near the pituitary or hypothalamus. I found this graph and I really like it because it talks about different things that can elevate prolactin, but also how high the prolactin goes. My general rule is that if you do have a high prolactin, I would always repeat it. And typically, levels under 100 nanograms per mil can be a lot of different things. Certainly medications, severe hypothyroidism, renal failure, chest wall trauma, liver disease, and PCOS can affect it. Drugs that, micro and macro prolactinoma, if you have a level over 100, I would be very worried about a macro prolactinoma. And certainly if you have a level of 250, you should be calling your local endocrinologist. Really where the questions come in are, what do we do with levels that are sort of 15 to 30 to 40? So certainly if it's a level that's like 18, I'm not too worried about it, especially if it's a patient who's really stressed. But certainly if you have one that's a little bit high, I would repeat it. If you have a level that's persistently over 40 or 50, I definitely would send them to endocrinology, or don't hesitate to call endocrinology if you don't think that a full referral is needed. But certainly once it's consistently getting over the 30s, then I'd have a low threshold just to ask for advice. But overall, a lot of things can influence prolactin. And then finally, the thyroid. So going back to a final axis I'm going to go over tonight from the hypothalamus and pituitary. The hypothalamus makes thyroid releasing hormone, which talks to the pituitary to make TSH, which tells the thyroid to make both T4 and T3. And the thyroid makes about 80% T4 and about 20% T3, although the majority of T4 is converted to T3 in cells. And then thyroid hormone works on the thyroid hormone nuclear receptor in cells and has lots of feedback pathways. So TSH reference ranges I wanted to bring up because very importantly, they just changed the reference range in Alberta. And for a number of years, Calgary and Edmonton were quite different, where in Calgary, we had a lot of referrals for subclinical hypothyroidism where a TSH was like 5 or even 4. And so the new reference range, note that under 30 days of age, the TSH can actually be quite high. And there is a big surge of TSH release in a newborn baby or after a couple of days. And so it can go up to 25. But really, if you persistently have a TSH that's staying over 6.8 after you're 30 days old, then you definitely want to talk to your local endocrinologist. And the reference range typically after a year is 0.2 to 6.5 on the new reference range. Overall, the big take home point would be the reference range has changed. So we would now consider a TSH under 6.5 to be normal. And historically on Netcare, you'll see a lot of a lot of values that are flagged as positive that are under 6.5. I wanted to focus on subclinical hypothyroidism because we get a lot of referrals in community endocrinology for this, and people really want a little bit of advice on how, like, when do you actually treat it and when do you worry about it? So subclinical hypothyroidism refers to a TSH that's between about 6 and 10, or it can be higher, but with a normal free T4. Typically, once your TSH is starting to get to 15 to 20, your free T4 is starting to go low. That may not always be the case. When your TSH is between 6 and 10 and you have a normal free T4, about 90 to 95% of kids will actually have no progression. They may just be a child whose baseline TSH is just a little bit higher than the rest of the population. And we certainly follow it over time to make sure it doesn't evolve, because about 5 to 10% of children who initially have a TSH between 6 and 10 and normal free T4 will go on to develop hypothyroidism. They would have a higher risk of going on to hypothyroidism if they had a positive anti-TPO antibody, or if they had trisomy 21, or any other genetic risk factors. With the recent change in the reference range, we definitely have fewer false positives, because before we were getting referrals for subclinical hypothyroidism when a TSH was like 4 or 5. But certainly when a TSH is between 6 and 10 and you're wondering, how much of the child being a little bit tired, a little bit constipated, because it could be the thyroid, but lots of other things can cause that. If you have a 6 and a 10, typically I would repeat it a couple of times with a free T4 over a number of months. When I decide to treat primary hypothyroidism, I always do when a free T4 is under 10. You can consider treating it when a TSH is persistently over 10 and there are clinical symptoms. And this point comes from the American Thyroid Association. So the American Thyroid Association says in kids, when your TSH is over 10 and there aren't any symptoms, you definitely don't need to start Synthroid. And it's a big decision because if you start Synthroid, typically you're committing a child on that for long term. But when the TSH is persistently over 10 and a child very consistently seems to have symptoms, whether they're really tired or constipated or they're not growing in height very well, then certainly you could consider treating. I'm going to shift gears a little bit and also talk about other important things to know about TSH. The newborn metabolic screen I mentioned for a different endocrine condition. The other endocrine condition on the newborn screen we're always trying to pick up and not miss is a TSH for congenital hypothyroidism. And in some parts of the US, they actually will use a free T4. We use a TSH. And not everyone will encounter this, but a lot of family physicians and community pediatricians will encounter a child in their practice who has congenital hypothyroidism. I did mention in the very first thyroid slide that a TSH under 25 or up to 25 can be considered normal in the first 30 days of life. But essentially, if it's over 25, but under 50, you'll get a borderline screen on the newborn metabolic screen, and they will actually repeat the screen. And there's a whole protocol about when you would decide to actually start Synthroid. If the newborn screen has a TSH over 50, Synthroid is immediately started and the family doctor is contacted to make sure that the endocrinologist gets labs, and this would urgently be sent to a pediatric endocrinologist. So just because we're talking about thyroid and its endocrinology, I just wanted to put a plug in for newborn metabolic screening and how important TSH is, but also how the TSH reference range is quite different in the first month of age. And a TSH of 25 to 50 would be considered borderline on a newborn screen. But certainly if you're getting a TSH of 25 to 50 because you've done random labs in an infant, I would definitely have a low threshold to talk to an endocrinologist. I wouldn't convince yourself that a TSH of 30 or 40 in an infant is normal by any stretch. And a TSH over 50, essentially, Synthroid needs to be started immediately within 24 hours. And congenital hypothyroidism is a modern miracle where if we don't treat in the first 2 months, there can be very severe, long-lasting developmental delays. But if we start Synthroid in the first couple of weeks of life, these children essentially grow up, and other than having to take a pill every day, and they get very good at swallowing Synthroid as infants, they are essentially undistinguishable from other children. And then I wanted to move on to free T4 and free T3. And so I do have a little graph here that shows that essentially shows what we expect the TSH and free T4 levels to be. I usually only order free T4 for hypothyroidism. So when I order it, it's to confirm a primary hypothyroidism, and also if I want to rule out a central hypothyroidism, and also to monitor the dose of Synthroid for hypothyroidism. I always order it with a TSH. And this little figure on the right essentially shows that in primary hypothyroidism, you have a low free T4 and an elevated TSH. Subclinical hypothyroidism, which I mentioned before, was where you have a normal free T4 and the TSH can be elevated. And we look at whether it's consistently elevated and how high before we even consider is treatment needed. And then secondary hypothyroidism, TSH can be normal or it can be low, but really when you're worried about a central hypothyroidism, for example, in someone who's had a brain tumor around the pituitary or congenitally, you're only focusing on your free T4 and your TSH won't be meaningful. The other thing is, when do I order a free T3? I only use it for hyperthyroidism. I know that a lot of people will order it with a free T4. I really don't think that for hypothyroidism, it really gives you any value. When I'm worried about Graves' disease or I'm worried about a thyroiditis, there tends to be a free T3 predominance in Graves' disease. And so really hyperthyroidism is when I'll order it. And if I do think it's Graves' disease, then I'm also ordering additional tests and not just relying on a free T3. And then finally, thyroid-related antibodies. The anti-TPO level is commonly positive in patients with Hashimoto's thyroiditis, and many people will use an anti-TPO level if they think that subclinical hypothyroidism might evolve or there might be more risk factors. And so definitely many people will order it. Many people will order it to confirm a diagnosis for hypothyroidism. In my practice, in my colleagues' practice, we very often don't use it. We typically will decide treatment for hypothyroidism based on a TSH and a free T4, although that's practitioner dependent, and some people do find it adds value for their diagnosis. Typically, I find that making decisions on treatment for hypothyroidism, I get enough information with a TSH and free T4. Many healthy people actually have a positive anti-TPO but no thyroid disease. So ordering it, if you get it and you have subclinical hypothyroidism and you have a positive anti-TPO, I would be cautious in counseling patients on their prognosis for thyroid disease, because it is actually fairly common to have a positive anti-TPO in the general population with many people who don't have thyroid disease. And so I've put that there's no value in ordering it, but I also wanted to step back to this discussion of this slide with some other practitioners. Some people do order it in subclinical hypothyroidism. Thyroglobulin is a very specific one. Thyroglobulin is often ordered by people, but it's only useful, first of all, if the antithyroglobulin that is processed at the same time is negative. If you have a positive antithyroglobulin, you can't order, or you can't actually interpret a thyroglobulin level. But neither of these tests are useful for screening for thyroid disease in primary care. Thyroglobulin is really only useful for monitoring specific thyroid cancer patients. And I know that's been a bit of a whirlwind in endocrinology. And so I wanted to see if there were any questions.
Thank you very much, Kate, for that road trip down those tests and for the great summary with all your clinical pearls. Maybe I'll ask a question just for clarification. So, and as an adult endocrinologist, I know we don't sometimes do the same things in adult and pediatric and endocrinology. But for the adult world generally, and I know Choosing Wisely has suggested to avoid doing a free T4 when monitoring or adjusting for standard autoimmune hypothyroidism. Is that a similar thing in pediatric endocrinology?
I think that pediatrics is probably a little bit slow on the uptake of Choosing Wisely. Usually the referrals that I'm getting from primary care, I find that most people are actually just using a TSH. I think that some of our guidelines, for example, around congenital hypothyroidism actually counsel on how to titrate for both a TSH and a free T4. So definitely in congenital hypothyroidism, really in keeping with the guidelines, endocrinologists would definitely order both, whether that's out of habit or just the fact that we don't have new evidence. I think it's actually probably very valid to just adjust based on a free T4. And to be honest, that might be something that in my own future practice, I need to look for evidence on.
You mean TSH?
Doing a free T4 for hypothyroidism. Most endocrinologists, pediatric endocrinologists do it, and we probably need to step back and examine the evidence for that. So it may just be a bad habit. So I think that we're all working on Choosing Wisely, and that might be an area of study that might need to be studied in pediatric endocrinology.
Thanks. We have a question. Thank you for this best presentation. Is there any update about autism endocrine labs?
I'm wondering if someone can explain to me what those are, because I'm not actually sure what autism endocrine labs refer to.
I'm not certain. Perhaps if the question asker can clarify the question, because I'm not familiar with any particular autism related endocrine labs. Laboratory tested needed for autism like growth, etc.
So I'm just going to say it's not something I've encountered. Typically, there isn't a clear association between any hormone conditions and autism, although there are many endocrine conditions with genetic, or essentially with a genetic condition that would cause autism. So there aren't any screens that I would typically advise. I don't know if that's helpful, but I just haven't actually encountered it, and I'm not sure if it's coming from a guideline, but it's not something that I've routinely seen.
Thank you. The next question is, how common is hypothyroidism in the pediatric population?
So I am going to say that I have a very biased perspective. It's kind of when people ask me, do I think that early puberty is becoming more common? And I say, well, in my office it is, but we also get all the referrals for it. So, I mean, I'd say that there's probably a fairly high, I mean, there are many pediatricians will see primary hypothyroidism. Typically, age 6 and up is when we would expect an autoimmune disease causing hypothyroidism. So certainly, I don't know exact numbers off the top of my head about the prevalence. I see lots of kids with it, lots of pediatricians manage it. So it's actually quite common. So I think really if you have a child who has clear symptoms, or specifically if you have a child whose weight is going up disproportionately, but their linear growth is stunted, that would be a really important time to measure a TSH and a free T4 to look for hypothyroidism.
Do you know, do you know what the guidelines are, or what the pediatric endocrinologists are recommending if patients have autoimmune, say type 1 diabetes or celiac disease, how frequently they should be screened for autoimmune hypothyroidism?
So hypothyroidism, typically, there's a Diabetes Canada guideline, and I believe it is annually, or at least every 2 years. And so the Diabetes Canada guideline on pediatric type 1 diabetes will have that with the table. But I typically would screen annually, but it could be every 2 years. I think celiac is every 2 and TSH is every year.
Thank you. Are there any other questions? Well, thank you so much for that great review. And we appreciate all your feedback. So please do take a few minutes to complete the evaluation form, which can be found at the QR code on the screen. Oh, we've got another question. Would you continue screening type 1 diabetes patients in adulthood with yearly TSH also?
I'm actually going to redirect that to our resident adult endocrinologist.
Yes, please. So the lifelong risk of developing autoimmune hypothyroidism, or even actually I'll broaden it out to autoimmune thyroid disease, which could be both hypo or alternatively, they can also develop autoimmune hyperthyroidism or Graves' disease. So we do advocate for yearly screening of TSH to be added on to the standard yearly diabetes screening for renal complications in adults with type 1 diabetes. And celiac disease, we generally advise checking every few years or if patients become symptomatic. So we're not as strict on that. Would you say clinically that's what you're doing as well? Yeah. Okay. Well, thank you so much. It's been a pleasure having you tonight. And I would also like to invite the attendees to also let us know what you're interested in learning so we can continue to provide high quality talks through the Office of Lifelong Learning. So thank you, take good care, and stay safe out there.